Let's get to the first, which is how might the recent FDA approval of a reduced dosing schedule of TEC impact patient experience and quality of life? So why don't we, all of you don't have to answer that. Maybe one or two of you weigh in on that question.
So I'll start. I think it's not only less burdened on treatment for patients, but I do think it will reduce. I mean, we all recognize that the way these drugs were initially developed, it wasn't that the weekly schedule was, they said, well, let's look at the PKs and this is what makes sense. But I think as we get more and more experience, we see that weekly scheduling probably just adds toxicity and doesn't necessarily increase efficacy. So I think and as we get more and more patients responding, what we're now going is to monthly treatment for very deep responders, and they're doing very well.
Anybody else want to take it on? From my perspective, the reduce in infection rate by going to every other week. And certainly at our center, at a certain point, we go to once a month dosing for all of these bispecifics, because when the tumor burden is so low, I don't know that you really need that much antibody floating around in the blood. Okay. Let's go to the next question. What do you all know about the rationale for administration of alnuctamab via IV rather than sub-Q? And I will say, I think they are switching to sub-Q, but certainly is there a difference that you all are aware of between IV and sub-Q dosing?
I think are you speaking about alnuctamab or just all of them in general? Because all of them came out with IV first, right? And then switched to sub-Q. So I think that's just generally, and the side effect profile doesn't seem much different.
Yeah, interestingly, the off rate of the antibody may be higher if you give it IV than sub-Q, and that might actually reduce T-cell exhaustion because the half-life may actually be a little bit shorter. So if you keep the same schedule or the abbreviated schedule that I think many of us are talking about, IV actually may be a better way to deliver the drug from an immune perspective than sub-Q, where you have the much longer half-life. But those are theoretical issues.
I mean, the only real thing I think is important to comment is the timing of CRS obviously is very different with IV and sub-Q, and that just has to do with drug delivery and timing to reach peak concentration. It tends to be delayed 2 days with sub-Q.
Yeah, and Amrita, I want to bring up something that Sergio brought up earlier, which is the administration of IVIG. It sounds like, Sergio, you guys are doing what we have historically done for other myeloma agents, which is wait until patients show us that they're going to get an infection before we give prophylactic or preemptive IVIG, if you will. At our site, we start giving it in cycle 1. We have it built into our EPIC orders because we know everybody gets hypogamma pretty quickly, and we didn't want to risk an infection. But I'm curious how all of you approach that at your centers.
So I would say at our center, we do very similar to what Dr. Gerald's doing at Sloan Kettering is, at the first side of like infection or when IgG levels drop below 400. I think ideally I would like to do what you do, Dr. Loyal, which is just kind of like build it into the EPIC order set and get it started. But there's sometimes some limitations to that.
Yeah, we have planned a randomized trial because we do think that, particularly now in the real world setting, that if you go do IVIG for everybody who has less than 400, you're going to do a lot of IVIG that may not necessarily benefit a significant proportion of patients. Now, I think essential is as we start patients on these, if anybody has had a history of prior serious infection, just without having had any antibodies, then we would think those patients should be started on prophylactic IVIG because they're a setup for a serious infection. And one serious infection can, as we see, there have been deaths on these trials from infection, not from myeloma.
Yeah, I agreed. Amrita, I don't know if you do it differently or.
We're sort of in between, so I don't wait till patients have an infection, and most of us, our group, don't. We do it driven by levels, and some of that is also just payer driven that we can't get authorization until it is less than 400, but we don't wait till they get an infection to declare themselves.
So I'd like to ask the panel, so how about, I mean, now that we have real world, what is your feeling of trying to do tumor cytoreduction with a DCEP-like or other forms of treatments, and then use these drugs as consolidation for another response, partly as a way of trying to minimize the toxicities of these drugs by minimizing tumor burden?
I think that would be, I'm sorry, Dr. Leno, go ahead.
No, go ahead. Go ahead, please.
No, I think that would make sense to me too, because when we look at a lot of these studies, right, like the median time for response is at the very minimum 4 weeks or a month, right? So if the pace of the disease is pretty boring or aggressive, I do think that debulking the disease with more of a classical alkylator, old school chemotherapy backbone, just to bring the disease down, and then give time for the BCEP, for any bispecific for that matter, to kind of kick in, and then keep for the more long-term benefit. That approach would make more sense to me. The one thing I do worry about is that, do we end up kind of killing more T cells than we need to? And that's sort of like the concern, is like, is DCEP too much? Do you just need a little bit of cytoxin? Like, what's the right pudding, so to say, which one should we use?
Yeah, I would echo that. I think these drugs are so effective on their own. I don't think the side effects are a significant issue, and we're giving preemptive toci for every one of our patients, and then 75% are being treated as an outpatient with preemptive toci. So the ramp up and the toxicity is not an issue for us, and it looks like Amrita shaking her head in agreement as well.
Yeah, I mean, I think the grade 3 CRS is literally in the single digit percentages, and so I actually would not favor. In fact, we're moving more and more away from chemotherapy based, even in the pre-CAR T bridging space now. Obviously using talquetamab post-Luc pre-apheresis. So again, speaking to I find the actually onset of response is relatively quick. I think it just speaks to T cell health. Patients are going to respond within the first 2 cycles or not. You see very quickly, really. So I think it's more combinations with the bispecific is really what we need.
So there's one question in the chat that I want us to get through real quickly, because we're already 2 minutes over. So this will be perhaps the last question. While sequencing bispecific after bispecific, would you sequence one immediately after another, or do something else in between?
I guess I'll go. I guess I'll go. I would do something in between. And sort of like, what would you do in between is sort of kind of one of the unknowns, which we have to sort of find out in the next couple of years, hopefully. And again, this is with the caveat that this is progression on one, and then trying to pick a second bispecific as opposed to like switch maintenance or something. I do think that one of the mechanisms of sort of resistance is T cell exhaustion, right? So if we think that has some role to play into progression, then switching from one bispecific to another one, which albeit might be to another marker on the plasma cell, but still needs T cells to work, may not sort of be the best bet for that patient at that time. And doing bridging with something in between is what would sort of lead to giving a break and letting the T cells come back a little bit.